Oral medicine 5th stage, white and red lesions. 1. A white appearance of the oral mucosa may be caused by a variety of factors. Hyperkeratosis. The oral epithelium may be stimulated to an increased production of keratin. Acanthosis. Abnormal but benign thickening of stratum spinosum.
Acanthosis. Abnormal but benign thickening of stratum spinosum. Intra- and extracellular accumulation of fluid in the epithelium may also result in clinical whitening. Microbes, particularly fungi, can produce whitish pseudomembranes consisting of sloughed epithelial cells, fungal mycelium, and neutrophils, which are loosely attached to the oral mucosa. A red lesion of the oral mucosa may develop as the result of atrophic epithelium, reduction in the number of epithelial cells, or increased vascularization, that is dilatation of vessels and or proliferation of vessels. Classification: 1. Infectious diseases, 2. Premalignant lesions, 3. Immunopathologic diseases, 4. Allergic reactions, 5. Toxic reactions, 6. Reactions to trauma, 7. Other red and white lesions. Infectious diseases. Oral candidiasis. 1. Oral candidiasis is the most prevalent opportunistic infection affecting the oral mucosa. In the vast majority of cases, the lesions are caused by Candida albicans, C. tropicalis, and C. glabrata. The pathogenesis is not fully understood, but a number of predisposing factors have been shown to convert C from the normal commensal flora to a pathogenic organism. C is usually a weak pathogen, and candidiasis is said to affect the very young, the very old, and the very sick. The local predisposing factors are able to promote growth of the yeast or to affect the immune response of the oral mucosa. 1. Denture wearing. 2. Smoking. 3. Inhalation or topical steroids. 4. Hyperkeratosis. 5. Imbalance of the oral microflora. 6. Change in quality or quantity of saliva. General predisposing factors are often suppress the adaptive or the innate immune system, so can affect the susceptibility of the mucosal lining. Immunosuppressive diseases and immunosuppressive drugs, impaired health status, chemotherapy and radiotherapy. Endocrine disorders. Most candidal infections only affect mucosal linings, but rare systemic manifestations may have a fatal course. Oral candidiasis is divided into primary and secondary infections. The primary infections are restricted to the oral and perioral sites, whereas secondary infections are accompanied by systemic mucocutaneous manifestations. Pseudomembranous candidiasis. The acute form of pseudomembranous candidiasis, thrush, is grouped with the primary oral candidiasis and is recognized as the classic candidal infection. The infection predominantly affects patients taking antibiotics, immunosuppressant drugs, or having a disease that suppresses the immune system. The infection typically presents with loosely attached membranes comprising fungal organisms and cellular debris, which leaves an inflamed, sometimes bleeding area if the pseudomembrane is removed. Less pronounced infections sometimes have clinical features that are difficult to discriminate from food debris like egg and yogurt. Oral candidiasis. The erythematous form of candidiasis was previously referred to as atrophic oral candidiasis. However, an erythematous surface may not just reflect atrophy but can also be explained by increased vascularization. The lesion has a diffuse border, which helps distinguish it from erythroplakia, which usually has a sharp edema marcat. The infection is predominantly seen in the palate and the dorsum of the tongue of patients who are using inhalation steroids. Other predisposing factors that can cause erythematous candidiasis are smoking and treatment with broad-spectrum antibiotics. Chronic plaque type and nodular candidiasis, candidal leukoplakia. The chronic plaque type of oral candidiasis replaces the older term, candidal leukoplakia. A white irremovable plaque characterizes the typical clinical presentation, which may be indistinguishable from oral leukoplakia. A positive correlation between oral candidiasis and moderate to severe epithelial dysplasia has been observed, and both the chronic plaque type and the nodular type of oral candidiasis have been associated with malignant transformation.
Denture stomatitis. The most prevalent site for denture stomatitis is the denture-bearing palatal mucosa. It is unusual for the mandibular mucosa to be involved. Denture stomatitis is classified into 3 different types. Type I is limited to minor erythematous sites caused by trauma from the denture. Type 2 affects a major part of the denture-covered mucosa. Type 3 has a granular mucosa. The denture serves as a vehicle that accumulates sloughed epithelial cells and protects the microorganisms from physical influences such as salivary flow. The microflora is complex and may, in addition to C. albicans, contain bacteria from several genera, such as Streptococcus, Veillonella, and Lactobacillus. Angular cheilitis. Angular cheilitis presents as infected fissures of the commissures of the mouth, often surrounded by erythema. The lesions are frequently co-infected with both Candida albicans and Staphylococcus aureus. Vitamin B12 and iron deficiencies, atopy, and loss of vertical dimension have been associated with this disorder. Dry skin may promote the development of fissures in the commissures. 30% of patients with denture stomatitis also have angular che. Median rhomboid glossitis. Median rhomboid glossitis is clinically characterized by an erythematous lesion in the center of the posterior part of the dorsum of the tongue. As the name indicates, the lesion has an oval configuration. This area of erythema results from atrophy of the filiform papillae, and the surface may be lobulated. The etiology is not fully clarified, but the lesion frequently shows a mixed bacterial/fungal microflora. Smokers and denture wearers have an increased risk of developing median rhomboid glossitis, as well as patients using inhalation steroid. Sometimes a concurrent erythematous lesion may be observed in the palatal mucosa, kissing lesions. Median rhomboid glossitis is asymptomatic, and management is restricted to a reduction of predisposing factors. The lesion does not entail any increased risk for malignant transformation. Diagnosis and laboratory findings. The presence of Candidal microorganisms as a member of the commensal flora complicates the discrimination of the normal state from infection. It is imperative that both clinical findings and laboratory data in the following table are balanced in order to arrive at a correct diagnosis. Sometimes antifungal treatment has to be initiated to assist in the diagnostic process. Treatment for fungal infections, which usually include antifungal regimens, will not always be successful unless the clinician addresses predisposing factors that may cause recurrence. Whenever possible, elimination or reduction of predisposing factors should always be the first goal. Smoking-induced erythematous candidiasis in the palatal mucosa. Clinical appearance after cessation of smoking. Antifungal medications. The most commonly used antifungal drugs belong to the groups of poly-NS or azoles. Poly-NS such as nystatin and amphotericin B are usually the first choices in treatment of primary oral candidiasis. Poly-NS are not absorbed from the gastrointestinal tract and are not associated with development of resistance. Topical treatment with azoles such as miconazole is the treatment of choice for angular cheilitis. Systemic azoles may be used for deeply seated primary candidiasis such as chronic hyperplastic candidiasis, denture stomatitis, and median rhomboid glossity. There are several disadvantages including heavy checkmark interaction with warfarin, leading to an increased bleeding propensity. Heavy checkmark development of resistance. Antifungal medications, topical, nystatin, as cream or oral suspension, 100,000 you apply after meals 4 times/d, usually for 7d, and continue use for several days after POS clinical healing. Amphotericin B lozenge, 10 mg slowly dissolved in mouth 3-4 times/d after meals for 2 wk minimum. Miconazole oral gel or cream apply to the affected area 3-4 times daily and continue for 10-14d after the lesion heals. Systemic fluconazole capsules 50-100 mg capsules once daily for 2-3 wk ketoconazole tablets 200-400 mg tablets taken once or twice daily with food for 2 wk. Oral hairy leukoplakia. It's mostly seen in patients with HIV disease since other states of immune deficiencies, such as caused by immunosuppressive drugs and cancer chemotherapy, have also been associated with OL. Rarely, individuals with a normal immune system may present with OL. Etiology and pathogenesis. Oral hairy leukoplakia is strongly associated with Epstein-Barr virus and with low levels of CD4+ T lymphocytes. Antiviral medication, which prevents EBV replication, is curative and lends further support to EBV as an etiologic factor. Clinical findings. The lesion is asymptomatic, typically appears white, corrugated, folded or carpet-like in nature on lateral border of the tongue bilaterally, but may also be observed on the dorsum and in the buccal mucosa. Diagnosis. A diagnosis of OL is usually based on clinical characteristics, but histopathologic examination and detection of EBV can be performed to confirm the clinical diagnosis. Management. Oral hairy leukoplakia can be treated successfully with antiviral medication.
White and red lesions part 2. 2. Premalignant disorders. A. Oral leukoplakia and erythroplakia. Oral leukoplakia times. Oral leukoplakia is defined as a white lesion of the oral mucosa that cannot be characterized as any other definable lesion. Times the prevalence of oral leukoplakia is 2.6%. Times most oral leukoplakias are seen in patients beyond the age of 50 years. Etiological factors, idiopathic, but these are predisposing factors, tobacco usage, either smoking or chewing, betel nut chewing which kept in the area of the lower mucobuccal fold, which produces lesions on the buccal mucosa. Alcohol, candidal infection viruses, leukoplakia increase in AIDS, hairy leukoplakia, EBV, HPV-16. Clinical findings. Times the lesion is asymptomatic in most patients. It may vary from a quite small and circumscribed to an extensive lesions involving a large area of mucosa. Times lesions may be white, whitish yellow or grey, and any site of oral mucosa can be involved. Times the floor of the mouth and the lateral borders of the tongue have been considered high-risk sites for malignant transformation. Clinical types. Times 1. Homogeneous leukoplakia is clinically characterized as a white, often well-demarcated plaque with an identical reaction pattern throughout the entire lesion. The surface
Texture can vary from a smooth and thin to a leathery appearance with surface fissures sometimes referred to as cracked mud. Times to dot the non-homogeneous type of oral leukoplakia may have white patches or plaques intermixed with red elements, so it's also called erythroleukoplakia and speckled leukoplakia. Times verrucous or verruciform leukoplakias where the white component is dominated by papillary projections, similar to oral papillomas. The malignant potential is very high. A homogeneous leukoplakia at the left buccal mucosa. Erythroleukoplakia. A proliferative verrucous leukoplakia in an 80-year-old woman. Erythroplakia times erythroplakia is defined as a red lesion of the oral mucosa that excludes other known pathologies. Times oral erythroplakia is not as common as oral leukoplakia, and the prevalence has been estimated to be in the range of 0.02%, 0.1%. Times the lesion comprises an eroded red lesion that is frequently observed with a distinct demarcation against the normal appearing mucosa. Times erythroplakia is usually asymptomatic, although some patients may experience a burning sensation in conjunction with food intake. Times clinically, erythroplakia is different from erythematous OLP and erythematous candidiasis as both have more diffuse border. In addition, OLP usually surrounded by white reticular or papillar structures. Erythroplakia at the alveolar ridge. The patient later developed a squamous cell carcinoma. Diagnosis. The diagnostic procedure of oral leukoplakia and erythroplakia is identical. The provisional diagnosis is based on the clinical observation of a white or red patch that is not explained by a definable cause and confirmed by biopsy. The histopathologic features of the epithelium may include hyperkeratosis, atrophy, and hyperplasia with or without dysplasia. When dysplasia is present, it may vary from mild to severe. Treatment of leukoplakias and erythroplakia. Small black square elimination of the predisposing factors. Small black square surgical excision, as well as laser surgery, is widely used to eradicate leukoplakias and erythroplakias. Small black square retinoid have antiproliferative and differentiating effects on human AP cells. Also, it decreases the risk of recurrence or second primary lesions, and it is antioxidant, decrease lesion size and reversed dysplasia. Small black square follow-up. B. Oral submucous fibrosis times. It is a chronic disease affecting the oral mucosa, as well as the pharynx and the upper two-thirds of the esophagus. Etiology and pathogenesis times. There is dose dependence between areca quit chewing habit and the development of this oral mucosal disorder. Times areca nuts contain alkaloids that affecting the metabolism of collagen, which leads to an increased fibrosis. Clinical findings times. The first signs of oral submucous fibrosis are erythematous lesions, followed by a paler mucosa. Times the most prominent clinical characteristics will appear later in the course of the disease and include fibrotic bands located beneath an atrophic epithelium. Increased fibrosis eventually leads to loss of resilience, which interferes with speech, tongue mobility, and a decreased mouth opening. Times the atrophic epithelium may cause a smarting sensation and inability to eat hot and spicy food. Management times. Treatment should be focused on cessation of the chewing habits and patients follow up since it has malignant potential. 3. Immunopathologic diseases. Times A. Lichenoid reactions. Times B. Lupus erythematosus. 4. Allergic reaction. A. Reactions to dentifrice and chlorhexidine. Times delayed hypersensitivity reactions to toothpastes and mouthwashes have been reported. The compounds responsible for the allergic reactions may include flavor additives such as cinnamon or preservatives. These flavoring constituents may also be used in chewing gum and produce similar forms of gingivostomatitis. Times the clinical manifestations include fiery red edematous gingiva, which may include both ulcerations and white lesions. Similar lesions may involve other sites, such as the labial, buccal, mucosa and tongue. Reaction to dentifrices. 5. Toxic reactions. A. Reactions to smokeless tobacco. Times smokeless tobacco can be divided into 3 different groups: chewing tobacco, moist snuff, and dry snuff. Times in its mildest form, the lesion may just be noted as wrinkles at the site of application, whereas high consumers may display a white and leathery lesion, which sometimes contains ulcerations. Times gingival retractions are the most common adverse reaction seen in conjunction with a smokeless tobacco habit. B. Smoker's palate. Times 1. The most common effects of smoking are presented clinically as dark brown pigmentations of the oral mucosa, smoker's melanosis, and as white leathered lesions of the palate, usually referred to as nicotine stomatitis or smoker's palate. Times 2. In smoker's palate, an erythematous irritation is initially seen, and this lesion is followed by a whitish palatal mucosa reflecting a hyperkeratosis. Times 3. As part of this lesion, Red dots can be observed representing orifices of accessory salivary glands, which can be enlarged and display metaplasia. Times 4 smokers' palate is more prevalent in men and is a common clinical feature in high consumers of pipe tobacco and cigarettes and among individuals who practice inverse smoking. The etiology is probably more related to the high temperature rather than the chemical composition of the smoke, although there is a synergistic effect of the two. 6. Reactions to trauma. Trauma reaction to mechanically. Morsecatio times 1 morsecatio is triggered by habitual chewing. This parafunctional behavior is done unconsciously and is therefore difficult to bring to an end. Times 2 morsecatio is most frequently seen in the buccal and lip mucosa and never encountered in areas that are not possible to traumatize by habitual chewing. Times 3 morsecatio is 3 times more common among women. Morsecatio has a very typical clinical appearance, and the diagnosis is relatively easy to establish, with one exception. If the lesion affects the borders of the tongue, it may mimic hairy leukoplakia. Times 4 the management is limited to assurance, and the patient should be informed about the parafunctional behavior. B. Frictional hyperkeratosis times oral frictional hyperkeratosis is typically clinically characterized by a white lesion without any red elements. Times the lesion is observed in areas of the oral mucosa subjected to increased friction caused by, for example, food intake. Clinical findings times frictional hyperkeratosis is often seen in edentulous areas of the alveolar ridge but may also be observed in other parts of the oral mucosa exposed to increased friction or trauma, such as sharp tooth, cheek biting, and prolonged wearing of often ill-fitting dentures. Times chronic irritation must be identified which fits the size and shape of the lesion, and the lesion must resolve when the cause is removed. Reaction to thermal trauma. Actinic cheilitis times is a common alteration of the lower lip caused by chronic exposure to sunlight. The ultraviolet produces cellular damage to both the epithelium and the underlying connective tissue. Times fair-skinned individuals are much more affected than blacks. Times the injury is a chronic process requiring decades of excessive sun exposure. Therefore, affected patients are usually over 60 years of age and report an outdoor hobby. Times it is a premalignant lesion and biopsy usually reveals dysplasic cellular features. Progression to carcinoma is often associated with cofactors such as smoking. Times clinically lower lip appears thin and atrophic with focal homogeneous, milky white patches of the atrophic lip. Times management times protection from sun exposure and discontinuation of habits such as smoking. Any indication of progression to early carcinoma needs excisional biopsy.
White and red lesions. 3 Oral medicine. Dr. Mohammed Hassan. 7 Other red and white lesions. A benign migratory glossitis, geographic tongue. Geographic tongue is an annular lesion affecting the dorsum and margin of the tongue. The lesion is also known as erythema migrans. Etiology and pathogenesis. Although geographic tongue is one of the most prevalent oral mucosal lesions, there are virtually no studies available with the objective to elucidate the etiology behind this disorder. Heredity has been reported, suggesting the involvement of genetic factors in the etiology. Clinical findings. Typically, affected tongues have a bold, red area of varying sizes that is surrounded, at least in part, by an irregular white border. The appearance of the affected portion of the tongue results from loss of filiform papilla. The peripheral zone disappears after some time, and healing of the depapillated and erythematous area starts. The clinical appearance may vary from single to multiple lesions occupying the entire dorsum of the tongue. Geographic tongue is characterized by periods of exacerbation and remission with different durations over time. The disorder is usually non-symptomatic, but some patients are experiencing a smarting sensation. Patients often report that their lesions are aggravating during periods of stress. Geographic tongue and fissured tongue may be observed simultaneously. A geographic appearance can be rarely observed at other sites of the oral mucosa than on the dorsum of the tongue, and then is denoted geographic stomatitis. An increased prevalence of geographic tongue has been observed in patients with generalized pustular psoriasis. But no studies have demonstrated that patients with geographic tongue are at increased risk of acquiring psoriasis. Management. 1. As the etiology is unknown, no causal treatment strategy is available. Symptoms are rarely present, and the management is confined to proper information about the disorders. Benign character. 2. When symptoms are reported, topical anesthetics may be used to obtain temporary relief. Other suggested treatment strategies include antihistamines or steroids, but none of these has been systematically evaluated. B. Leukoedema. Etiology and pathogenesis. The etiology of leukoedema is not clear. Clinical findings. 1. Leukoedema is a white and veil-like alteration of the oral mucosa that is merely considered a normal variant. The condition is often encountered bilaterally in the buccal mucosa and sometimes at the borders of the tongue. 2. Leukoedema is less clinically evident after stretching the mucosa but reappears after this manipulation is discontinued. In more pronounced cases, leukoedema is accompanied by mucosal folds. The condition is asymptomatic and has no malignant potential. Management: there is no demand for treatment as the condition is non-symptomatic and has no complications, including pre-malignant features. C. White sponge nevus. White sponge nevus is rare autosomal dominant disorder, and the clinical appearance usually commences during adolescence, and the gender distribution has been reported to be equal. Clinical findings: 1. The typical clinical appearance is a white lesion with an elevated and irregular surface comprising fissures or plaque formations. 2. The most affected sites are the buccal mucosa, but the lesion may also be encountered in other areas of the oral cavity. The disorder may also involve extraoral sites, such as the esophagus and anogenital mucosa. 3. Although the lesion does not entail any symptoms, it may cause dysphagia when the esophagus is involved. Diagnosis: 1. White sponge nevus may constitute a differential diagnostic problem as this disorder may be taken for other oral dyskeratoses, for example, oral leukoplakia and plaque type. Candidiasis. 2. The hallmark microscopic feature of this disorder is pronounced intracellular edema of the superficial epithelial cells, predominantly located within the stratus spinosum. Cells with pynotic nuclei are present, and these cells may imitate coilocytosis observed in viral infections. No or just mild infiltrations may be seen in the subepithelial tissue. Management: white sponge nevus does not entail any symptoms, and no treatment is therefore required. D. Hairy tongue etiology and pathogenesis. The etiology of hairy tongue is unknown in most cases. A number of predisposing factors have been related to this disorder, such as 1. Neglected oral hygiene. 2. A shift in the microflora. 3. Antibiotics and immunosuppressive drugs. 4. Oral candidiasis. 5. Excessive alcohol consumption. 6. Oral inactivity. 7. Therapeutic radiation. 8. Smoking. The impact of ignored oral hygiene and oral inactivity is supported by the high prevalence of hairy tongue in hospitalized patients who are not able to carry out their own oral hygiene. Clinical findings: 1. Hairy tongue is characterized by an impaired desquamation of the filiform papilla, which leads to the hairy-like clinical appearance. 2. The elongated papillae have to reach lengths in excess of 3 mm to be classified as hairy, although lengths of more than just 15 mm have been reported in hairy tongue. 3. The lesion is commonly found in the posterior 1/3 of the tongue but may involve the entire dorsum. Hairy tongue may adopt colors from white to black depending on food constituents and the composition of the oral microflora. Patients with this disorder may experience both physical discomfort and aesthetic embarrassment related to the lengths of the filiform papillae. Management: the treatment of hairy tongue is focused on reduction or elimination of predisposing factors and removal of the elongated filiform papillae. The patients should be instructed on how to use devices developed to scrape the tongue and continuous tongue brushing.